Hello, my name is Angele Heinsman, and I'm a consultant with the Alberta Medical Association. I'm here to present to you about alternative relationship plans and the blended capitation model. So let's jump in. What does ARP stand for? Well, it's an alternative relationship plan, and when we talk about the mechanisms by which physicians in Alberta get paid, traditionally we think about fee for service. And that's where individual clinical services have a fee code attached to them, and those are used whenever that clinical service is provided. Each code attracts a specific amount of payment. ARPs are different in the way that physician compensation occurs. Sometimes you might hear about a clinical ARP or CARP, and in general, these are just different ways in which defined groups of services are put into what we call a basket, and there's a compensation plan for those baskets of services. Typically, it's not dependent on the same criteria as fee for service, such as having to see the whites of the eyes of a patient, and there's fewer time limitations. So Alberta Health looks at these alternative relationship plans as different ways in which services can be provided to Albertans and ways in which they can maximize the ability to deliver service in the most effective ways. So in order to join any one of the ARPs, there are some defined processes. Generally, they start with either an expression of interest or perhaps an application. Anyone that is looking into joining an ARP needs to understand that there's probably a significant amount of paperwork and forms that need to be completed associated with joining any one of the ARPs. So there's three kinds in existence. There's an annualized payment model, which in some examples are provided to a geographic area. And one example you might think of is the Tabor Clinic. And there's also academic ARPs. For example, in the Edmonton area, you have family medicine clinics connected to hospitals. Usually, there's one attached to the Grey Nuns Hospital, the Royal Alexandra, and others. And I know that there are University of Calgary family medicine clinics as well that are in those academic ARPs. Those ARPs help with delivering services alongside residents and medical students and other kinds of medical learners. And there are quite a few in the specialty care area as well. And what it does really is hold some time for those academic clinicians to do some research and teaching activities as well as their usual clinical services. Then there's a second type, which we'll call the sessional ARP, and very often you'll hear some of the AHS-supported ARPs talking about an amount per hour they get paid to deliver particular services. And then the third one is blended capitation, which we're going to spend our time on today talking about. This one's supported by AMA and others, and we'll talk about the supports a little bit later on. And finally, the key piece mentioned at the bottom of this slide is that all of these types of ARP are established through a ministerial order. In terms of support, I think the key message is that we want you to know that it really is a partnership. The Blended Capitation Model project is supported by Alberta Health and the AMA, and we have contributions from Alberta Health Services in continuing to promote the project and align policies within AHS and AH, and we're all equally in support of this project. What we hope you take away from this presentation is that the Blended Capitation project was designed to specifically remove the economic disincentives for the patient's medical home. So we're thinking about what kinds of clinics in Alberta that the BCM project would be best suited for, and we think about those clinics that have really embraced the principles of the patient's medical home. So starting with those principles and then going forward into the ARP for blended capitation is the preferred path, rather than looking at this ARP as a way to implement the patient's medical home. So it should start to become obvious as we are talking today about how the model incentivizes particular behaviors. So you'll see why we want to start with clinics who have a good foundation and grounding in the patient's medical home. And the animation here just shows that the capacity for improvement and engaged leadership are pretty key to this prior to joining blended capitation. And team-based care is also really critical, and having good paneling processes and continuity, and of course, care coordination would be a bonus as well. All of this together should really result in better patient-centered interactions. So when a visit, a physician no longer has to consider what they might be able to bill for, but what the patient really needs from the clinical team. So we're still in a testing phase. It's a demonstration project at this point. And phase 1 started off with the Sylvan Family Health Center going live in 2017. And then there were some model enhancements made after working with Sylvan Health Center and other stakeholders, looking at what could be improved. And there was a redesign workshop that took place in 2018, where we looked at how we could improve uptake of the model and some of the amendments to the amount of negation, which I'll describe further on in the presentation. And there were some changes to the amount of fee for service that could be billed for patients that were not affiliated to the clinic. All of these changes helped really with some of the early concerns about how the model was working. And then in phase 3, we have 5 more clinics that have joined the model, which takes us to a total of 6. And we're aiming for 10 to do an initial evaluation of the model to see where we're at. Blended capitation really does require a change in mindset. So with fee for service, basically you do the work and then you get paid. Whereas with blended capitation, you get paid and then you do the work. You're paid a capitation amount per patient at the beginning of the payment period. And then you can make this shift to deliver care in different ways or innovative ways and to maximize your team's capacity and scope without worrying about being compensated for every single interaction with patients. This really helps clinics to think about changing the way they might use their team, how they might interact with patients a little differently, and how you could structure the clinic's agreement among physicians to support this new model of care. So I've used the terminology a basket of services. And really, this is a collection of codes that are typically used by family physicians. So we might talk with physicians on the model about in-basket and out-of-basket service, and that really impacts on the payments they get. And this is really how blended capitation works. And this slide shows how the payment components are put together. So payment is made up of 2 parts. 85% of clinic payments come from a capitation rate, which I'll talk more about on the next slide. But essentially, each patient is assigned a capitation rate based on their age, gender, utilization, and complexity. Clinics get 85% of that rate automatically upfront, no matter what, and that represents the clinic's stable income. The other 15% is made up of fee-for-service billings, as clinics do now, but they get paid 15% of the normal fee-for-service rate. So once a clinic has patients affiliated, which means that they've agreed that they are the patients of the clinic, and that's been validated by Alberta Health, you would receive capitation rates for those patients, no matter how often, if ever, they visit you or your clinic. You also receive 15% of any of the in-basket codes that you use when you see those patients. In blended capitation, billing codes are either designated in-basket or out-of-basket, and those 54 health service codes reflect typical activities of a family physician in an office-based setting. So if you use an in-basket code, you get 15% of the normal fee-for-service rate. If you use an out-of-basket code, you are compensated at 100% of the fee-for-service rate. Now, many clinics from time to time will also see patients who are not affiliated. There's no agreement that they're on your panel, and you're not receiving capitation rates for those patients. But for those patients, you can bill up to 2 in-basket fee-for-service codes every 2 years. Out of basket, there's no limit, and you get 100%. Now, negation is the tricky part. Because blended capitation is predicated on the idea of continuity, if a patient who is affiliated to your panel seeks care elsewhere and an in-basket code is used, the model essentially says that the BCM clinic could have provided that care or that service, and you're negated at 100% of the fee-for-service code for the service used. So this includes if patients seek care outside of your zone. Let's say they're on holiday in Banff and hurt themselves, go to a walk-in clinic, or even if they use a virtual app like Babylon and Maple. The physicians on Babylon do bill their services to Alberta Health. So a couple of things to note here. In this pilot, negation is waived for the first year. So for your first year, you'll receive reports that show what your negation would have been to allow you to work on process and delivery redesign and engage in some patient education. Negation starts in year 2. And another thing is that Alberta Health recognizes that not all negation is avoidable. So there's a 7% negation forgiveness on the total dollar amount of negation in that second year and moving forward. So income is made up of 15% fee for service for in-basket, 85% cap rate, and 100% of out-of-basket codes for affiliated patients, and up to 2 fee for service codes for non-affiliated patients per 2 years, minus negation. So when we use the term negation, it automatically puts people into a negative mindset. So maybe instead of thinking about your first year as negation free, and then all of a sudden you're going to be penalized in the following year, we like to encourage you to think instead that if you do your very best job possible to keep patients connected through your own virtual care options and keeping your access really open, that you'll be able to keep patients coming through your door for the majority of their care. And we know that there are appropriate referrals to other family medicine physicians, like for example, sports medicine, that will cause negation. But this is why there's some negation forgiveness. It's also important to remember that you're paid for some patients that aren't going to use their visits at all. So it's important to understand the balancing nature of the model. Patients may not come to see you, or they saw your nurse, but you still get your capitation rate for them. And if you have a patient who starts to visit really frequently, all of a sudden, it balances out with those patients that you're getting paid for that don't come in at all. And that patient that starts to come in more frequently is likely to have a capitation rate increase in the following year if their conditions and their utilization has changed. So this diagram represents how the capitation rate is calculated. There's 9,500 different cohorts, and these are determined by patient age, gender, complexity, and the patient's projected health system costs. Capitation rate is intended to be a reflection of their utilization in the past, and it's based on the CHI population health profile groupings. So it's evidence-based and based on data around each specific patient and what their projected visit rate will be, their projected cost to the system, and their prescription drug use. So you can see that little funnel at the bottom. All of that data about each patient goes into a calculation to understand what their cap rate should be. Another area of the model that requires a bit of a mindset shift is that payments are made at the clinic level, not to individual physicians. So there are conversations that physicians and clinics need to have around how those payments get distributed amongst the clinic. So conversations like how overhead is taken off, is it off the top, or does everyone get their share of payment and then pay their overhead separately, things like that. So this needs to be ironed out through conversations in advance, things around the practice agreement and a financial distribution model. Every clinic does this slightly differently, but lots of clinics talk about whether they want to do what might be called internal negation. So for example, when a physician is covering for your colleagues or a lot, or providing services to another physician's panel, the question is whether or not you would want to adjust the income received. So that's really up for discussion. But one thing that we do notice is that clinics that consider going forward with blended cap are going to make more money, and that additional funding could go to fund more interdisciplinary team members. So as you can see, you could hire additional nurses, pharmacists, practice facilitators, social worker, etc. Expanding your team might allow you to increase your panels and add more patients to your roster. So continuity is the factor that really drives your financial pluses and minuses. With blended capitation, the payment is received regardless of whether the patient sees a physician or the interdisciplinary team, whereas with fee-for-service, patients have to see the doctor for payments to be received. No payments are received when the patient sees a team member under fee-for-service, whereas if you have 100% continuity to the clinic with a patient under blended capitation, the clinic gets 100% of the money. In reality, with fee-for-service, negation does happen. You might just not know about it. Or you might know if your billing for a complete physical is denied, for example, or you can also tell on your CII CPAR reports if patients have said that they have a different family doctor. But if your patients aren't coming to you for care, they're going somewhere else, and under fee for service, you're not getting paid. So access is really the key to continuity here. If your patients can get access with the team and physicians, then you can maximize your team, maximize their scope, and you might also do a bit better financially. Blended capitation clinics often want to know whether they can grow their panel, and we usually do say yes, but you also need to make sure that there's a balance, that you don't compromise access by taking on additional patients. So that's another reason to consider growing the team so that you can keep your access really open. That first year of negation-free time is a really good time for your clinic to think about whether there's some patient education you can do, or if there are different ways that we can be available to our patients so they don't have to go elsewhere. I wanted to include a testimonial from our first blended capitation clinic, Sylvan Family Health Center. They've been on the model for 4 years now, and they've said that transitioning to blended capitation, while it did have its challenges, it also provided significant rewards for the team, the patients, and the physicians. It opened doors to further their medical home implementation, which might have been difficult under the fee-for-service structure. So that's why we say blended capitation incentivizes moving towards the medical home model by expanding the team. That gives you the ability to panel more patients as long as you don't compromise access. There might be different ways of caring for patients and meeting their needs with team-based care under the model. And patients can become a little more educated on that importance of continuity and how it might affect their health. One of the quotes from Sylvan says, "There have been challenges, but none of us would go back to fee-for-service." There's also supports to blended capitation clinics. AMA, our ACT team, and the health economics team support blended capitation clinics on aspects of process redesign, both clinical and administrative. There are some administrative issues to work through when a clinic first starts. For example, every patient has to sign an affiliation form, and currently Alberta Health requires a wet signature on a piece of paper. Unfortunately, although there has been a bit of reprieve to this during COVID, they have allowed this form filling to be done electronically. There's also some administrative processes around changing the way that patients can be booked in. So for example, when a patient calls and says, "I have this particular issue," the front desk needs to know whether they can book the patient with a nurse or a social worker, or if they do truly need to see the physician. Our team can help with scripting these interactions and looking at algorithms that could be used for the front desk to make those decisions. We can help with change management in terms of team development and things like the practice agreement, financial distribution models, and our health economics colleagues are really helpful with this and with billing supports around individual codes and how they might be used, or how things might change with blended capitation billing. We also host a community of practice every other month for blended capitation clinics, which is a really great forum for all the clinics that are on the model or those that have committed to joining the model. We also held one last year where it was clinics who had expressed interest in the past, sort of an Ask Me Anything session, and that was pretty well attended. Alberta Health is a really important partner in all of this with us. We meet with them regularly to talk about where different clinics are at, and of course, they're the ones that provide the ministerial orders that you heard about earlier in the presentation. They also provide the financial modeling, which is very key to most clinics as to deciding whether or not to go forward with blended capitation. They also support the required forms and billing requirements, and they'll work through all of that with the clinics in a very hands-on way. There's a very huge, as you might imagine, technical back end for all of this at Alberta Health, where all the payments and billings, et cetera, go through. So just to sum up the key messages from this presentation, you heard about a few different types of ARP. They're all a little bit different based on the ministerial order. So there's no one single type of ARP. Blended capitation is the ARP that's supported by AMA with our partners in Alberta Health and Alberta Health Services. Blended capitation clinics have the opportunity and more importantly, the incentive to move towards the patient's medical home by improving continuity and through the expansion of team-based care. So please don't hesitate to reach out to us if you have questions. Again, my name was Angèle Heinzman. My email address is on the screen. Thank you so much for listening.